So after a day and a half of lectures, you are definitely over the hump, or as they would call it on the West Coast, the mountain. I relatively recently, just last fall, moved from Portland, Oregon, back to this area, and there's an awful lot that the DC area offers, but one thing I do miss is being able to look out your window and seeing Mount Hood. It's just incredibly peaceful and calming. So my objectives of this talk are very similar to Karen's last talk that we just heard, which is to make you as comfortable as possible with seizures in half an hour. But knowing our approach hopefully will make you as comfortable as possible. So what I'll start doing is to review the general approach to seizure and epilepsy treatment that is based on what we know about the outcomes in seizures based on epidemiological data. And I'll also talk about how we approach choosing anti-seizure medications based upon the type of seizures that the child has had and whether they have a specific diagnosis of a specific epilepsy syndrome. There are a number of slides that you can access on the online syllabus that detail particular medications. Those are just meant to be for your resource. But I will mention in general what monitoring needs there are, what general side effects we are concerned about, and talk a little bit about interactions between medications. I'll also briefly mention a few of the newest generation of anti-seizure medications, just so you've heard those names so that you're familiar with them when some of your children are put on them. Before we get to talking about treatment, though, I just want to spend a couple of minutes to go over the basics of seizures and epilepsy, just to make sure that we have the foundation to move forward with. So the first step in seizure management is questioning, are we truly dealing with seizures? And that's because, especially within pediatrics, there are many non-epileptic events that look like seizures, that mimic seizures, that sound like seizures, but that aren't seizures. So when we diagnose a seizure, what we're talking about is a sudden clinical event that is caused by the abrupt, uncontrolled, hypersynchronous electrical discharges of a pool of neurons. Now, epilepsy, when we say epilepsy, it often conjures up a negative picture, a stigma to the family. But really all that it refers to is a condition characterized by the tendency for recurrent, unprovoked seizures. So when we make a diagnosis of epilepsy, we're considering whether we should put this child on daily preventative medication. And of course, Statusepilepticus refers to seizure activity that lasts 30 minutes or longer. In reality, of course, practically speaking, 4 to 5 minutes is what we care about. This is based upon the epidemiological data that most seizures will last less than 4 to 5 minutes long. So that's when we trigger our parents to either call EMS or to administer rescue medications. Now, when you talk to an epileptologist, that last bullet there also is a concern that we have, that prolonged or repeated seizures will actually lead to reinforcement of those epileptic pathways and actually make it more difficult for us to treat seizures down the road. So knowing what seizures look like, how we can classify seizures, is the first step in deciding whether it is that this patient had a true seizure. So one way of classifying seizures is by the onset. Where in the brain was the abnormal electrical activity when it started? Did it start all over all at once, or did it start just in one part of the brain? So we divide those into primary generalized and partial or focal onset. Under primary generalized, we have generalized tonic-clonic, so obviously a phase of tonic muscle stiffening, and then a phase typically of clonic activity, rhythmic jerking. We also have absent seizures, so very typically brief 10 to 15 second long periods of activity arrest, unresponsiveness, followed by no postictal phase. Myoclonic, so a sudden jerk of the body or a jerk of a limb that's related to sudden muscle contractions. Tonic, just increased tone of the muscles. Atonic, loss of tone. So when we hear about drop seizures, we will very often think about whether they could be due to tonic seizures or atonic seizures if they truly were due to seizure activity. Then there's partial or focal onset, and how we divide those up. We can think of simple partial seizures. So that area of abnormal electrical activity was so small that it didn't affect the person's consciousness. Could just be if it was the motor cortex, just clonic activity, and the person may be very well aware that they're having a seizure and be able to talk to you about it. Now, if that activity spreads to enough of the cortex where the consciousness is altered, then that's what we call complex partial seizure. Then, if the abnormal electrical activity then spreads to the opposite hemisphere, then that can lead to a secondarily generalized seizure, generalized tonic-clonic seizure. So that brings up the point that when we see a kid with a true generalized tonic-clonic seizure, we don't know if it was primary generalized or secondarily generalized. We can ask about some features like, did they have an aura or a warning beforehand? Did they have eye deviation to one side or the other? Did they have any asymmetry of the body movement? Those may be clues that they actually had a partial onset. One other thing that I just put in quotes there is the term petit mal or petite mal, and that's just to remind ourselves that that term is still used very commonly, and really just to refer to an episode that wasn't so dramatic or impressive as a grand mal seizure. But when we hear petit mal or petite mal, that brings to mind whether the seizure was an absent seizure or a complex partial seizure, both presenting potentially with an alteration of consciousness. Now this video illustrates the evolution from a simple partial seizure to a secondarily generalized seizure. It's a teenager. His mom is sitting to our right. So you'll see his eyes go down. He's getting a sensation that something's happening. So this is his aura. This is the simple partial portion of the seizure. He motions over to his mom to let her know. And then you're going to start to see him have some automatic, non-purposeful movements of his left hand, what we would term motor alternatives. He has some lip smacking now. Now, mom's unfortunately very used to this. She's going to look at her watch in a second and try and time the seizure. The only thing she forgets to do is to take a piece of gum out of his mouth. Now we're going to start to see some forced head deviation to the right. And now we're getting the sense that there's spread of that seizure activity. It's really forced. She shouldn't necessarily be trying to hold him down, but by doing that, we get the sense that his muscle tone is really increased, so he's entering the tonic phase. There's that pixel cry, probably from air being forced out of the vocal cords. And now he's going into the chronic phase. I'm going to stop here and give you some more of the same clonic activity, but his seizure actually lasts about 2.5 minutes long, so we've gotten to probably about a little over 2 minutes. So that's a very typical time frame for a seizure. All right, so the other way that we can classify seizures is by syndrome. So I'll remind you about what syndrome means. It's a cluster of symptoms, signs, and lab findings, for instance, EEG, which tend to go together, they're consistent, and then imply a diagnosis, a particular treatment that could be helpful, or a particular prognosis. So for instance, within pediatrics, we have epilepsy syndromes like infantile spasms or West syndrome with mental retardation, infantile spasms, chaotic-looking EEG. We've got Lennox-Gastaut syndrome. Many children who have infantile spasms go on to have Lennox-Gastaut syndrome with mental retardation, multiple different seizure types. Those are what we would consider some of the more catastrophic epilepsy syndromes. Some of the benign, quote-unquote, epilepsy syndromes are absence epilepsy, benign Rolandic epilepsy, and then there's juvenile myoclonic epilepsy that tends to occur in adolescence. Now, why are we talking about epilepsy today? Well, the pediatric brain is very hyperexcitable, and that's for a number of different reasons. Interestingly, the inhibitory receptors in the neonatal brain tend to be excitatory. But the other thing that I talk about a lot with my parents, because they understand this, is that in kids, the density of synapses is very high. They haven't started having dying off of their neurons as we already have. So it's a setup for them to have a pool of neurons all firing off hypersynchronously all at once. And that's reflected in the epidemiological data. The risk of having a single seizure by age 20 is greater than 4%. The risk of having unprovoked seizures repeatedly by age 20 is greater than 1%. The risk of epilepsy, this is relatively old data, in what is approximately a lifetime is about 3%, with the peak occurrence in childhood and in older people. So what do we do when we see a child who has just had one unprovoked seizure? Well, we go back to the epidemiological data and try and figure out what are our risks that this kid is going to have another seizure in the future. If that child is otherwise normal, normal brain, normal EEG, the data suggests maybe anywhere from 20 to 50% recurrence risk within the next 2 years. If you add on an abnormal EEG, it goes up to about 50%. But the way that I see that, it's still 50-50. It's a toss-up. Now, if the kid is otherwise not normal, there's something abnormal about their brain, then of course the risk goes above 50%. The important thing to realize based upon the data is that there's no difference in the chance of the seizures remitting if you wait to start a medication after the second seizure versus the first seizure. So that's why after a single unprovoked seizure, the treatment really involves reassurance. And this is extremely important. Most of the patients' parents that you see that have had a generalized tonic-clonic seizure, they will say that they thought that their child died. So it's reassurance, but it's also making sure that the child is safe if indeed they do end up having another seizure in the future. So I talk about no unsupervised baths or swimming, not even leaving them in the bathtub for a minute to answer the doorbell. They should be biking with a helmet anyways, but not biking in traffic. And in those children who have had seizures at nighttime, or if the parents are extremely anxious, I will suggest a baby monitor at the most. Then I will also counsel them, educate them about what seizures can look like, that it's not always just a generalized tonic-clonic seizure, that they can be more subtle, for instance, like a complex partial seizure, so that their antennas are up, their radar screens are up. And I'll also counsel them about what to do for first aid if the child has another seizure, in particular if it's a grand mal seizure, generalized tonic-clonic seizure. It's amazing how many people still think that you need to stick a spoon into somebody's mouth. And then if it was a prolonged seizure greater than 5 minutes long, 4 to 5 minutes long, I will also prescribe a rescue medication in the event that they do have another prolonged seizure. Now then, moving on though to say if the child has had more than one unprovoked seizure, and I'm thinking about a daily preventative anti-seizure medication. We try to be scientific about what we do. In general, the mechanisms of action of seizure medications are you want to increase inhibition, you want to decrease excitation. There are lots of different mechanisms of action, some of which we have a clear understanding of in many of our medications. Many of our medications, though, have several different mechanisms of action, and some that are just not clarified as of yet. In general, though, the mantra with our treatment of seizures is no seizures and no side effects. And it's those side effects that prompt us to perform routine monitoring. Now the problem is oftentimes that routine monitoring isn't going to catch some of those idiosyncratic reactions, some of those adverse reactions that happen just out of the blue, the fulminant hepatic failure, the pancreatitis, as opposed to the dose-related side effects. But we still do, I think, partially for our own comfort, partially to reassure the families. So for the older quote-unquote medications, the phenytoin, dilantin, the phenobarbital, the carbamazepine, Tegretol, the valproic acid, Depakote, in general, for the older medications, I will do baseline before starting the medication, a CBC, electrolytes, check their hepatic function and their renal function, and then I'll want to do that at least once after they have started the medication. And then after that, approximately every 6 to 12 months. For the newer medications, which tend not to have as many of those adverse reactions, is you don't necessarily have to check routine blood work. But I will do that occasionally if I'm concerned about noncompliance and I want to check if they actually have a blood level of that medication. If I want to optimize the medication, I keep going higher and higher and I want to make sure that I'm actually achieving a level. If I'm concerned about medication interactions causing unpredictable levels, or if the kid is doing fine and I just want to see where I'm at just to document what that level is when they're doing well. Otherwise, though, moving along to just talking about the specific seizure medication choices is, again, I base it upon seizure type, primary generalized versus partial or focal onset, and whether there's a specific epilepsy syndrome. So this is a table based on really consensus of what might be the first choice medication with different seizure types. And again, I've put that first choice in quotes because we're going to be thinking about the potential side effect profile, we're going to be thinking about the cost, the ease of administration, all of those factors are going to come into play. But for instance, with primary generalized seizures like myoclonic seizures, I would think about valproic acid. For partial onset seizures, I would think about carbamazepine. So in general, for primary generalized seizures, I would think about valproic acid, I would think about lamotrigine, Lamictal, I would think about levetiracetam, Keppra. Otherwise, in partial onset seizures, I would think about carbamazepine, Tegretol, or oxcarbazepine, Trileptal. Again, if there's a specific epilepsy syndrome, that may help us pinpoint a seizure medication that tends to be more helpful. So for instance, neonatal seizures. The most data on seizure medications in neonates is on phenobarbital and phenytoin. There has to be a lot more. Those are not the ideal. We're starting to use Keppra or levetiracetam a little bit more as well because the safety profile seems to be good. I'm going to talk a little bit more about absence epilepsy because that's the one that you're going to see the most and actually that many general pediatricians might be comfortable with treating themselves.
A bit tired.
Okay, keep going just a little longer.
4, 5, 6, 7, 8. So that was a very typical absence seizure. So roughly 8 seconds. And that's something that I'll do in the office is when I see them starting to have a lapse of consciousness, I will start counting. That just helps me keep track. But then also I'll ask them what number that they heard me count. And that will also confirm to me when they started coming back. And this is a very simple provoking procedure that you can do in the office, hyperventilation. Absence seizures are very sensitive to hyperventilation. Okay, so absence epilepsy is the one epilepsy syndrome that we actually have some evidence-based data. You know, of course, everything in pediatrics is all about consensus and experience, but in epilepsy at least. By consensus, by history, we would always tend to use Statusepilepticus or Reassurance. And then we would think also about valproic acid and lamotrigine. Well, finally, in 2010, data was published from a randomized controlled multi-center NIH-sponsored study on absence epilepsy comparing those three medications. And what it showed was that Statusepilepticus and valproic acid were significantly more effective than lamotrigine. But that valproic acid tended to have more negative effects on attentional measures. So it actually confirmed what we have been doing all along. Now the rest of the slides again are just for your resource, or the next number of slides. The column on the left are the so-called first generation anti-seizure medications. The column on the right, the second generation anti-seizure medications that came out between 1993 and 2000. And then these are the ones most recently that came out within the last 7 years or so since 2004. And these again are slides that you can access in the online syllabus, showing you when it came out, showing you the formulations that are available, the brand name, and the benefit side effects and some administration issues. So I'm going to run through these, and then just so you hear the names, some of the newest generation of anti-seizure medications, pregabalin or Lyrica. It's a cousin of gabapentin or Neurontin. It's actually not FDA indicated for children with epilepsy, but for partial onset seizures in adults. You may, of course, though, still see this being administered to some children with refractory epilepsy, also used for pain, neuropathic pain. There's lacosamide or Vimpat, which is indicated for partial onset seizures in adolescents and adults 17 years or older. Seems to be broad spectrum based upon animal models. One issue with this is potential dose-related prolongation of the PR interval. So we may be asking for you to help with occasional EKGs. But otherwise, no significant drug interactions or side effects. Another medication is refinamide or Banzel, which you may be seeing a little bit more because it is actually approved for kids 4 years or older with Lennox-Gastaut syndrome. You can see rash and hypersensitivity syndrome in this. It is contraindicated in the very rare familial short QT syndrome. It does have medication interactions, though, and one that may be related to general care is that it decreases oral contraceptive levels. There's a table within the prescribing information of other drug-drug interactions, and whenever in doubt, I always look in the prescribing information for specifics of that. Vigabatrin or Abril is approved now for infantile spasms. The reason why it took so long to get approved by the FDA is because of the relatively frequent occurrence of irreversible peripheral visual field constriction. This is keeping in mind, however, that many of our children with infantile spasms were not necessarily going to be worried about any sort of functional deficit that will come about because of peripheral field constrictions. All right, so moving along to more general thoughts or general topics related to anti-seizure medications and treatment. We, of course, worry about interactions with other medications, and the different mechanisms that are behind that are related to the induction of metabolism of medications, specifically usually via P450 system enzymes. So phenobarbital, phenytoin, and carbamazepine are P450 inducers. You can also see inhibition, though, of P450 enzymes by valproic acid. You can also see competition for protein binding between medications. The medications that often come up within general care, oral contraceptives and chemotherapeutic agents, those levels can be decreased, obviously, by P450 inducers. So oftentimes this is also a consideration when we think about which medications we want to start a child on. Antibiotics are tough. It's kind of a mixed bag. Penicillins themselves actually may lower, in theory, lower seizure threshold themselves. Ciprofloxacin can either increase or decrease anti-seizure medication levels. Anti-seizure medications can actually decrease metronidazole levels. There's a link. Epilepsy.com is a nice website that I like a lot, and there's a link that I just put up that goes to a list of drugs, anti-seizure medications, or other drugs that can lower seizure threshold. If you go to that link, also on that page, you can go to other links that talk about antibiotic interactions and other medication interactions. Again, if you're ever in doubt, call us or look it up on the prescribing information. The medications that often come up a lot when we think about lowered seizure threshold, parents come to us asking, is it okay that we take these medications because the box says it can induce seizures? Are antihistamines, stimulants, Sudafed. In reality, in practice though, lots of our kids are on stimulants for ADHD, and we don't tend to see an increase in seizures in those children. Antihistamines and Sudafed, I think about what they're treating. If the kid is congested, if they are not sleeping at nighttime, that in itself is going to lower seizure threshold. So it's all about that balance. Wellbutrin, Demerol, those actually do tend to be medications that do tend to lower seizure threshold. Another issue that may come up from your parents is the talk about suicidality with anti-seizure medications, because recently the FDA approved the updating of labeling of virtually all anti-seizure medications to warn about the 2 times increased risk of suicidality in people who are on anti-seizure medications. So therefore, the pharmacy, when the kids go to the pharmacy to get the medications, they're getting this new warning. But what we have to remember is that epilepsy itself is associated with an increased risk of suicidality. So we don't really know what the etiology of this is. Is it related to the medications or to actual brain neurotransmitter abnormalities? But bottom line is that all patients currently on or starting on any anti-seizure medication should be monitored. We should remember to ask about it and address it. I think you all are actually probably better than we are about asking. Another issue that has been coming up more and more now is complementary alternative medicine, or now a lot of people like to call it integrative medicine. A third of children with epilepsy have used complementary alternative therapies, including some of the agents that I've listed there. But we have to remember that there is actually contradictory data in animal models. Some of that data suggests that these are actually excitatory as opposed to inhibitory. But the Epilepsy Foundation of America has put out a policy or an opinion that CAM is acceptable as long as traditional therapies continue and they do not conflict with each other. But there has been suggestion that they occur under the guidance of medical professionals trained in herbal medicine. So if any of you are aware of or work with naturopaths, do let me know, because I would love to collaborate with somebody. But of course, referring to neurology, the helpfulness of that is education and reassurance. In the fall at our Montgomery County Clinic site, we're actually going to start having new onset seizure groups. So families who are new to seizures are going to be able to have a forum where they ask questions, where they get to know each other. So some of that peer relationship that Cara Biddle talked about will hopefully come out from that. And epilepsy camps. You guys probably know about our brainy camps for lots of different conditions, including cardiac and diabetes. But there is one for epilepsy camp that's going to be happening for 5 days in the middle of July. So if any of you have kids 7 to 16 years of age who have epilepsy, please do go on the website brainycamps.com and look that up. Of course, epilepsy management is what we as neurologists will do, especially for those who are medically refractory, have been through a number of medications and haven't had benefit. Then we might think about non-pharmacologic treatment. And these are the helpful references that I often access and that I recommend to my families. Epilepsy.com again. Epilepsy Foundation has a chapter here. The NIH.gov site you probably use quite a bit as well for your families. And then there's talkaboutit.org, which is particularly good for the kind of tweens and teenagers. It's actually was launched by an actor that I'm blanking on the name of because I don't watch TV anymore, but he was on Heroes, Alias. His son actually had epilepsy, and so there are a lot of actors in this website, and it's basically just to get kids to talk about it and to eliminate that stigma.